Welcome everyone, and thank everyone for attending this evening for Dr. Lackenpaugh's Venous Exchange. At this time, Dr. Lackenpaugh, you can take it away to provide more details and introduce tonight's presentation.
Perfect. Thank you, guys. Thank you, everybody, for joining. This is exciting. Thank you for spending your evening with us. We're going to make this as interactive as possible. So this is the next part of the series where last time you heard Dr. Laura Kelsey talk about overall thrombotic disease. So now, as promised at that time, we're going to take each individual segment of that. And this time, we're going to talk about superficial thrombophlebitis. But before we go into that, just some basic housekeeping things that please keep yourself muted during this process. If you have any questions, just email the question. Please, 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 any questions at all, do send them to us. The way we feel this CME is different is we're going to make it as interactive as possible. And today we are taking this to the next level where we also have two panelists. And the whole purpose is to make it as interactive as possible. And your questions can be submitted directly through the Zoom infrastructure. If you have any thoughts on what topics you would like to listen to in the future, please do send me an email. And let me again do some gratitude here. This is because of all your help and your trust in CVR. We are now at, I think, 96 centers. And every one of these centers, this is a group of physicians that helps us run these centers. It is the really painful detail that every one of these physicians show in collecting all the data that we can publish everything. They help us set up these talks, these CMEs. And with that very basic introduction of CVR, our speaker today is going to be Dr. Barajas. Luis is our regional medical director for Indiana. And our panelists today will be none other than our own chief medical officer, Dr. Wen, and the world's chief medical officer in venous disease, Nick Morrison. So with that, Luis, please take it.
Thanks, Sanjeev. So thanks again for joining tonight on this discussion on superficial thrombophlebitis. We're going to review today the incidence of SVT, the studies that kind of informed our treatment paradigms, look at the clinical applications regarding SVT, risk stratifying these patients, and then treatment for SVT. So really the goal of treating SVT is not only to help the patient with their immediate pain, but it's really to prevent them from entering another category of patients who have DVT. And it specifically prevent them from getting DVT in their proximal veins for which they may develop post-thrombotic syndrome. If they get that, 1/3 to 1/2 of patients with DVT can develop this syndrome. And it's really not a pleasant thing to see. Some of these patients are young, they're still working, and they have to deal with this chronic swelling and leg pain. And so we can prevent that from happening in these patients. So if we take a look, for example, at PE and SVT, the literature ranges the incidence of PE between 1% and 33%. It's not 33%, but the 33% comes from the small study that took 21 patients with isolated saphenous vein phlebitis and without cardiopulmonary symptoms. And 33% of them had a high probability of PE on a VQ scan. And this just illustrates that SVT really is a systemic coagulopathy that's occurring within our patients. The nomenclature has changed over the years. We now tend to favor SVT because it connotes some seriousness as to DVT. So let's take a look at a patient with a varicosity here. This is a varicosity from the anterior great saphenous vein. And then we have a thrombosed varicosity from the anterior great saphenous vein. So this patient of mine presented with a 2-week history of SVT from this tributary vein. Now, generally speaking, the clinical course of SVT is usually over 6 weeks. The first 2 weeks is what I call the hot phlebitis, where you can get dangerous extension or DVT. And about 2 weeks out, you start getting this discoloration of the patient. Now, this is not a saphenous vein. This is a tributary vein. The saphenous veins, you can't see or feel them on physical exam. So when you see this, you want to start asking, is this involving the great saphenous vein? If it is it extending thrombus near the junction? And is a common femoral vein already involved? Now, this particular patient, she had thrombosed her anterior great saphenous vein at the proximal thigh. She was non-tender there, but she has an acute thrombus there. And then it extended all the way to the saphenofemoral junction. Fortunately, she was treated. She did not develop DVT. If you have SVT of the calf varicosities, you want to think about involvement of calf perforators, any of the 3 main deep vein branches. Are they involved with this as well? And in this patient, you can see to your left there, the clotted varicosity, and to the right of the screen there, the gastroc deep veins are involved with this. And essentially, we're just not good enough clinically to ascertain the length of thrombus or other areas that are involved with thrombus of the lower extremity. We really need to get an ultrasound to assess these patients. Location of SVT, 60 to 80% of it is going to involve the great saphenous vein, 10 to 20 about the small saphenous vein, and 10 to 20 other veins of the lower extremity. If you have DVT with SVT, about half of those will involve the proximal deep veins, and 40% or so will involve the distal deep veins. Bilateral SVT is reported between 5 to 10% of patients, which would be an abnormal clinical presentation. And isolated GSV is always abnormal. That's estimated to be about 5 to 10%. So as an example here you have a patient with an isolated great saphenous vein phlebitis. Now, if the saphenous vein is within about 2 centimeters depth of the skin, it'll create a nice linear appearance there and help you diagnose phlebitis of the saphenous vein. If it goes deeper, or as we have many obese patients, you won't get that linear presentation. You'll get this bland, warm, tender, slightly red presentation. And this, of course, did not be treated for cellulitis. They need to be scanned to assess the vessels. So when we look at vein anatomy and SVT, you want to kind of connect the dots of what might be involved. So if you have thrombosed varicosities in the medial, anterior, posterior thigh, you want to think, is a great saphenous vein involved? Does it extend to the junction? Is a common femoral vein involved? If you have thrombosed varicosities in the anterior lateral thigh, that's the distribution of the anterior great saphenous vein. And of course, you want to determine whether or not the SFJ or common femoral vein are involved as well. Posterior calf varicosities, you want to think small saphenous vein involvement, saphenopopatial junction or popliteal vein. And then lateral medial calf SVT, you want to think are the deep calf veins involved with this as well. So the incidence is kind of all over the board, but we really think it's underdiagnosed. Some studies suggest that the prevalence is twice that of DVT and PE. Early references in the US suggested that maybe it's about 125,000 cases per year, but that's just not right. That's underappreciated. Probably better prospective data was from the STEP trial that had a community of about 260,000 people, and they tracked these patients over 1 year, and they found that the incidence was about 0.64 per thousand patients. And that is a little bit, that's just over half of what we think DVT is, 1 to 2 per 1,000. So the risk factors for SVT and DVT, they share similar risk factors. But risk factors for SVT, there's some more specific risk factors. Women tend to make up 50 to 70% of patients with SVT. Average age is about 60. Obesity is an independent risk factor. More than 70% have the presence of varicose veins. And then when we look at patients who develop a VTE event 3 months from the incident of SVT, the main risk factors are male gender, previous DVT, previous cancer, and absence of varicose vein. That's probably one many have not heard about, but absence of varicose veins is considered a risk factor for 3 months of occurrence of VTE. The 3-month mortality is still low as compared to PE. If you have a patient that has a history of SVT, their lifetime for getting a DVT is 4 to 6 times. And if you have a patient who's had a DVT compared to those who've had DVT with SVT, the rate of recurrence is double those with patients with SVT. And this is kind of the big slide here. You have kind of the 3 major prospective studies that looked at SVT and tracked them out. And what we find here kind of consistently is that when patients present with SVT, about 25%, 1 in 4, already have concomitant DVT. And the other thing is that 10% of these patients have DVT that's not contiguous with the location of the SVT. In fact, if you looked at the patients who had DVT with SVT, 42% were non-contiguous. So again, this just illustrates that we can examine them clinically, but we really need to scan them to assess the true nature and extent of thrombosis. And concomitant symptomatic PE was about 5% on average with patients presenting with SVT. So kind of the key points with the post-study, 25% had concomitant DVT, 60% of that was distal and 40% of that was proximal, about 4% PE. Less than 1% had isolated contralateral DVT. So you're probably safe in just ultrasounding the affected leg, but at the bare minimum, you have to look at the other leg to make sure there's not SVT that the patient's not noticing. We as a routine will scan the contralateral leg when we're assessing for DVT. 21% of the patients with isolated SVT had involvement of the saphenofemoral junction. And at 3 months, 10% of patients in the post-study still developed a VTE event, despite that 90% of them were anticoagulated. However, the duration of therapy for most of these patients was only 11 days. So what about cancer and SVT? So, we're kind of taught to think about migratory phlebitis and pancreatic cancer. So Purdue, he did a nice study here where he assessed the risk of subsequent cancer and arterial cardiovascular events. He reviewed over 2 years, it was a retrospective review over 2 years to assess the rate of cancer. So 737 of these patients had isolated SVT, not involving the SFJ, and 1,400 had comparable characteristics, which was the control group. And so the patient's demographics are very similar, kind of routine primary care diagnoses. And what he found was, in fact, there was no major differences for cancer development over 2 years in the SVT group as compared to the control group, nor was there any major differences in the arterial cardiovascular events either. The OPTIMIV trial, they also looked at cancer rates and found it to be similar to Perdone's numbers. They looked at the anatomic location of thrombus, whether it was isolated SVT or proximal DVT or distal DVT, found it to be about 3.4% over 3 years. So essentially, unlike DVT, SVT doesn't seem to be a strong predictor of cancer for first SVT episodes. So other than age-appropriate cancer screening, an exhaustive search for malignancy usually is not needed. So let's get to the treatments. So the initial treatments looked at using an NSAID and comparing that to enoxaparin. So in this study, it was double-blinded. They grouped patients to get prophylactic doses of enoxaparin or a therapeutic dose of enoxaparin or an NSAID, tanoxacam is a European NSAID, or placebo. And they treated them for 12 days. And what we found is that the placebo group had the highest, followed by the tanoxacam group. And we had a significant drop with the enoxaparin prophylactic and therapeutic dose. So essentially, it introduced low molecular weight heparin as better than NSAIDs for DVT prevention, but not really the duration and dosage. The Stockings trial was a better study. It used Fluxum, which is the Italian version of heparin, parnaparin. They randomized 664 patients, and now we're starting to look at lengths of thrombosis. They had to have at least 4 centimeters involvement of the saphenous vein or a tributary vein, and they were allowed to be included if they had previous DVT or SVT in the past 3 months. The primary outcome was a composite of symptomatic and asymptomatic DVT or PE or relapse of SVT. And the aim was to assess the efficacy and safety of intermediate dose low molecular weight heparin when compared to prophylactic doses, and also to see whether or not 10 days rather than 30 days were sufficient for SVT treatment. So the groups were Group A. Group A received intermediate doses of low molecular weight heparin for 10 days, followed by placebo for 20 days. Group B received intermediate doses for 30 days, and Group C received the prophylactic dose for 30 days. And so the short duration group had the highest incidence of a VTE of 15.6%, followed by the prophylactic dose. And of course, it was best for the intermediate dose at 1.8% at 30 days. And the overall risk reduction between the prophylactic and intermediate dose was 13.7. However, at 90 days, events began to rise again as far as VTE recurrence, which was the lowest for the intermediate group. So the take-home points for the Stockings study was prophylactic doses are clearly inferior to intermediate doses, so we should not use Lovenox prophylactic dose to manage patients with SVT. And also that the 30-day treatment is probably not long enough for patients with VTE risk factors. Just to touch a little bit on the intermediate enoxaparin dose. So therapeutic dose for Lovenox is 1 milligram per kg, and half that is considered intermediate dosing. So now the Callisto trial, that was an international multi-center randomized study that randomized patients receiving fondaparinux sub-Q versus placebo. And so knowing the previous studies, 30 days is probably not long enough, so we extended treatment to 45 days to avoid this catch-up phenomenon of recurrent VTE. The inclusion criteria included hospitalized patients and non-hospitalized patients. The length for this was 5 centimeters by ultrasound. They did not include patients with previous DVT in the past 6 months or documented DVT or P in the past 6 months. And mainly because those patients were at risk for another event. And so they wanted to create, so to speak, a safe placebo. So these patients, the outcome was a composite of death from any cause, the presence of symptomatic PE, DVT, extension of SVT at day 47. And the main safety outcome was major bleeding. Death was the same for both groups, and they were non-thrombotic causes. The fondaparinux group did much better, 0.9% VTE occurrence as compared to 5.9% of the placebo group. The overall risk reduction was about 85%. DVT in the placebo group, again, was about half and half, 52% was proximal and 47% was distal calf veins involved. And major bleeding for both groups was very low, 0.1%. So the take-home points for the Callisto trial was that fondaparinux is superior to placebo to prevent VTE and SVT extension. After 45 days, the efficacy seemed to hold through day 77 with no catch-up of another VTE event. So I called kind of the two major pharmacy retailers and kind of I got cash pricing on these drugs. And fondaparinux used to be more expensive, but looks like enoxaparin is actually getting a little more expensive. So it's definitely something that we can use. I tend to favor enoxaparin. I like the anti-inflammatory effects it has on patients who have SVT. So we know that the factor Xa inhibitors, they work very well for DVT, and it makes sense that it should do well for SVT. So now we have the surprise trial that randomized patients, 472 patients to receive either rivaroxaban 10 milligrams once daily, or fondaparinux sub-Q, again for 45 days. And in this study, they did include high-risk VTE patients older than 65, previous VTE cancer, or non-varicose vein SVT. And the primary outcome was a composite of symptomatic DVT, PE, or recurrence of SVT, and all-cause mortality at 45 days. The non-inferior margin was 4%, so it had to be less than 4% or less absolute difference between the two medications to consider it non-inferior. And the main safety outcome was major bleeding. So, and it worked very well. 3% of patients, as compared to 2% of patients with the fondaparinux group, had VTE events, and so it works very well. I think the majority of us use the factor Xa inhibitors in treating this. What about compression stockings? Compression stockings, there's only one study that I could find that compared the use of compression stockings in SVT. There were 73 patients that were randomized to using 20-30 weight compression stocking versus no compression. The main outcome was pain reduction. They also included thrombus length. And what they found is there wasn't a significant reduction in pain compared to the two groups. But the thing that really struck me is that the thrombus length seemed to decrease quicker in those who used compression. And so we always fit and size our patients for compression stockings. And I think in treating SVT, it's always been appreciated by the patients in terms of pain reduction. What about genetic factors? So we think maybe about 35% of patients with SVT have some kind of thrombophilia. In this study, looking at 107 patients, they compared patients who had non-varicose SVT to those who had varicose vein SVT. And you can see the incidence of thrombophilia is higher, with factor V Leiden being the most common thrombophilic factor in these patients who don't have varicose veins. Surgical versus medical management. Overall, there's a higher incidence of venothromboembolic events for those that are treated surgically without some kind of anticoagulant. So medical management is the way to go for these patients. There still is a place for surgery in patients who, for whatever reason, cannot be on anticoagulation. So if you look at the CHEST guidelines, based on the previous studies, they recommend that patients with SVT of the lower limb of at least 5 centimeters, they suggest prophylactic dose of fondaparinux for 45 days over no anticoagulation. Okay, let's talk about management. So when we talk about management, you can look at these patients kind of in 3 tiers: low risk, intermediate, and then high risk patients. The low risk patients are going to be patients with no major SVT risk factors that we discussed. Typically, they're going to be obese female patients with a cluster of varicosities not involving the saphenous vein. And so they should be less than 5 centimeters in length in terms of the thrombus. And we definitely need to, of course, get the initial ultrasound to assess the extent of thrombus and reassess them within 2 weeks for clinical extension. And of course, we provide supportive care, stockings, NSAIDs. I also recommend for these patients to not be afraid to give a little lidocaine to the areas that are most point tender and use an 18 or 16 gauge needle and just pop it through and try to drain out some of that old blood. That really helps with many of these patients with their pain, in addition to warm compresses and ambulation. And the main thing though is that these are patients, whether or not it involves the saphenous vein, they should have thrombosed varicosities. So if it doesn't have varicosities, they're a different category. So again, low risk, you want to think small clustered thrombosed varicosities with preferably no involvement of the saphenous vein and no SVT risk factors. Those patients you can reassess in 7 to 10 days. Intermediate risk patients will be patients with 1 or more risk factors. Again, we want to scan them, assess the involvement of the saphenous veins and deep system, and then repeat the ultrasound if they're not getting better. And these patients will be patients with either isolated SVT or patients with thrombosed varicosities that are more than 5 centimeters in length or within 5 centimeters to the junction. The treatment is going to be on enoxaparin 2.5 for 45 days, intermediate dose enoxaparin, or factor A inhibitor, in addition to the supportive care. At this point, we're really going to plan for definitive ablation of these diseased veins so they don't get recurrence and so that they just feel better. So intermediate risk group, you want to think large clustered thrombosed varicosities with saphenous vein length, involvement of 5 centimeters or more, and thrombus within 5 centimeters of the junction, or just isolated saphenous vein phlebitis. The high-risk patients are going to be patients who've had a previous DVT or who have a known thrombophilia, or who've extended despite being on a prophylactic dose, or if they have thrombosis within 3 centimeters of a junction. These patients, the consensus is generally to treat them as a DVT for 3 months. And that'll be good because we want to try to open up those diseased vessels so I can get in there with my ablative catheters and shut it down. So high-risk patients, think thrombus very close to the junction, recurrent SVT, patients with SVT and a history of DVT or known thrombophilia. So timing of clinical presentation is key in decision-making. So for example, you can have a patient with a 2-week history of SVT that's less than 5 centimeters. They seem to be doing better, and you want to put them in the low category risk. You definitely need to reassess these patients and probably rescan them to see if there's extension. That's different from a patient who presents with the same ultrasound findings, but it's only been 2 days. Typically, I will prophylax these patients, even though they're low risk, because they're probably not done extending in the saphenous vein. Ultrasound. So in our clinics, we assess the extent of thrombosis in the superficial and deep system, and we even compare the other side. If you get an ultrasound from institutions in a hospital setting or some other place, you're guaranteed to get assessment from the common femoral to the popliteal vein. But sometimes I found when I read these reports, they don't include the length of thrombus from the junction. Sometimes they don't include the calf veins, but usually they do. So if you're going to write an order in a patient who's got SVT, I would make a small note and in the order to say, please include the deep calf veins, the involved saphenous veins, perforators, and distance of thrombus from a junction, so you get all that data. And of course, we can be a resource for you. We do all that, risk stratification, follow-up management. You receive in detail our plan of actions, and we plan for definitive treatment of these disease veins with ablative techniques. So in summary, SVT, it's not a benign disease. It's really a spectrum of VTE. 25% of SVT can have concomitant DVT at presentation. 5% can have PE. Don't forget to look at the other leg, ask about chest symptoms, obtain a venous ultrasound to assess the deep system, reassess within a week to see if there's possibility of extension, and don't be afraid to get another ultrasound if needed. Remember the rules of 5s, 5 centimeter length, varicosity or saphenous vein, or 5 centimeters from the junction. You start treatment with prophylactic doses, as we talked about. And of course, don't hesitate to call. So thank you. Just to showcase here, we have Gaurav Lakhanpal. He's going to be presenting our next venous exchange on post-thrombotic syndrome. And as Dr. Lakhanpal mentioned, I am the regional medical director for Indiana, and we are looking for a provider to fill our need in Fort Wayne. So if you've ever had an interest in the vein field, please give us a call. You can email Bob Howell. He's our development manager. We'd be happy to have you. Thank you.
Well, Luis, thank you very much. This was absolutely amazing. You covered the topic so well from beginning to end. And that's really our purpose now, guys, to take each one of these smaller topics and cover them as exhaustively as possible. And we've got some questions coming. So I'm going to start with the first question, which is, is it appropriate to manage the SVT patient with just aspirin versus the use of nonsteroidals or Lovenox?
So that's going to be dependent again on the length of SVT and the ultrasound findings. So if they're low risk, then yes, you can use aspirin for pain
So
management.
Luis, do us a favor. I think this question really, and a lot of people walked in during different times of your talk, and even though you've covered everything, but take us through the journey of a patient. If you're in the clinic and a patient shows up with SVT of like the picture you showed, the anterior accessory vein, what goes on in your mind? And like I said, you've covered everything beautifully, but for people who may have walked in later,
Sure.
how does the diagnostic algorithm work in your mind, the clinical algorithm, the diagnostic algorithm, and the management part of it?
So, and the patient that presents with SVT, we want to assess, the risk factors, whether or not they've had previous SVT, or if we know whether or not they've had thrombophilia. And so let's assume that they don't have high risk factors. So, 5 centimeters really is not much. If you guys remember doing any OB, the peace sign for me, that's 5 centimeters. So I would bet that most patients presenting with SVT probably have 5 centimeters. And so, and the studies, they show that we're just not good enough to assess the extent of thrombosis, particularly as it involves the deep system. So the first step is assessing the legs involved, and then doing a venous ultrasound of the deep and superficial system to see how far it's extended. Is it just localized to the superficial system? Is the deep system involved? If the deep system is intact, then, and the patient is low risk and it's 5 centimeters or less, as long as you see them within a week, you can use aspirin. If it's extensive, like the first case I showed, it's well over 10 centimeters, then you want to use some form of anticoagulation, usually a factor 10A inhibitor. But I think a lot of people actually do like the anti-inflammatory effects of enoxaparin. I use that too. So yeah, you have to get the full picture on ultrasound to see the extent of it. And then from there, base your decision on whether or not to just use aspirin or whether or not we need to anticoagulate them.
So just using aspirin without everything else, am I hearing you say that that would not be adequate treatment? I mean, you've got to judge how long has this been going on for? What is the status of the deeper veins?
So basically, if it's more than 5 centimeters, they need to be anticoagulated at a prophylactic dose.
And Dr. Morrison, would you address this any differently?
No, I think things have changed considerably over the last few years. People used to think, and some still do, that SVT is a very benign disease and doesn't need to be followed. But we know now that it absolutely needs to be followed. At the minimum, needs to be followed by ultrasound and physical exam, and then anticoagulation when it's appropriate. We more readily start somebody on anticoagulation for this disease process than we did in the past.
Thank you. Ken, Dr. Wen, what are your thoughts on that?
So every patient is different, and whenever I assess a patient, I consider the clot burden. If there's significant inflammation, if the vein is markedly dilated, if just like Luis said, more than 5 centimeters in length, within 5 centimeters to the junction. Risk factors for that patient. Obviously, if there's a patient that's 80 years old and they have a risk for falling, and the SVT is in the lower part of the leg, in the calf, those are patients that very appropriately could be placed on aspirin. And as long as, like Nick and Luis have said, we monitor them very closely, it's very reasonable. So every patient that we see, you really have to weigh the risk and the benefits, and you look to see whether or not this patient is going to do worse on anticoagulation, or are they going to do better it all comes down to risk benefits. And we're happy to field a phone call from our referring physicians. Curbside consults, I love them. They're always fun for me. But everything that Luis and Nick said, we take it all in.
Yeah, and I think, Ken, what you just said, that's, listen, guys, use us as a resource. I mean, even if we are not in your area of referral, I mean, we are still not everywhere, but we pride ourselves in the fact that we are there to provide the best possible vein care to our patients, our collective patients. So please feel free. I think, as Dr. Morrison pointed out, that this is not as simple a disease as we used to think. So we really need to be there for these patients and treat them in every way possible. So Luis, our next question here is from Dr. Schul. Is there a role for a limited IND to reduce pain? And then he comments that the Italian consensus suggested that this is the most impactful intervention at presentation. Do you use IND at all?
Yes, quite a bit actually. I do find it to be quite a great pain reliever for these patients. I'm not certain if it changes the regression of the overall phlebitis, but from localized symptoms, it is quite helpful for these patients. And so for those of you who may not have done this, the blood is very slow flowing. They're not going to bleed out if you poke at these veins, but you will provide pretty good relief for these patients.
Nick, do you still do INDs on this, or you refrain
Absolutely.
from that?
Yeah, you'll make great friends with that patient if you do that, because they'll get almost instantaneous relief. Certainly by the next day, they're going to be feeling a lot better.
Great. So Ken, I'll ask you to take this next question. This is from Dr. Soul. As a podiatrist, I sometimes have patients that exhibit what seems to be a low-grade SVT. The patients come with no direct complaints of pain, but when I compress the GSV from distal to proximal, I usually find a localized area of exquisite pain. What do you do in a patient like that?
So, with any type of ultrasound study, there's two components, right? There's going to be a compression component, and then there's going to be a flow component, right? So if you're telling me that the GSV compresses and it's just painful there, and there's flow through it, then most likely there's probably not a true SVT, but more likely possibly reflux. So that patient probably needs a reflux study and also needs to make sure there's no DVT. But theoretically, if there's flow through it and there's compression through it, then and there's no signs of pain for the patient, then most likely I would say that patient probably does not have a true SVT and needs further evaluation for other causes of their pain.
Well, thank you for that. And Luis, we have another question here from Dr. Hollenbach.
Sanjeev,
What are your thoughts? Sorry, Nick.
Before you go on, let me make a comment about that.
Yeah.
Because I see it so often, I am absolutely convinced that people with venous insufficiency can get inflammation of their veins without clotting. So they'll come in and show you an area that's red, warm, and tender, and yet there's flow through that. I think that's an inflammatory process that stops short of actual thrombosis.
Mm-hmm.
And how do you treat it then?
Typically with simply with NSAIDs, but follow up just as well.
Okay.
NSAIDs will almost always allow it to settle down. But you talk to people, and historically they will give you this history of recurrent episodes like this, and yet the vein is open with flow, reverse flow, but it's there.
Fantastic. Thank you. And so this question, Luis, is from Dr. Hollenbach. What are your thoughts on patients that have recurring SVT in the GSV or the SSV, including into the varicose veins, and with the ultrasound showing reflux in patent segments? So let's first talk about just that. Recurring SVT in the GSV or SSV with extensions into the varicose veins or vice versa?
Yeah, so recurring phlebitis, that definitely is an indication to treat these patients with prophylactic doses. Also, really, these patients need to have a coagulopathy workup. I usually work with the hematologist for patients who are higher risk. Let's say patients with isolated saphenous vein phlebitis, even from the first onset, especially if they're younger, that's really not normal. And so they probably do need a thrombophilia workup. And also, you know, the goal really is to get rid of these diseased veins. I feel that really helps decrease their issues of recurrence and pain. So recurrent SVT is an indication for more of a workup.
Now, is recurrent SVT, I know you showed us that a single episode of SVT does not indicate any underlying malignancy. Is recurrent SVT more associated with malignancies or not?
You know, I couldn't find any solid numbers in the literature, but it does seem to be. It's certainly DVT is more associated than SVT, but we got to start, especially if the patient's older and they're getting recurrent phlebitis, to think about cancer, whether it's an adenocarcinoma, leukemia, or lymphoma. So that's why a lot of times I'll have these patients get examined by hematologists to cover my bases.
Yeah, Ken, I know you've had a few patients with the recurrent SVT and malignancies. You want to share at least one of your famous stories?
Yeah, so I completely agree with Luis and his presentation that single episode of unilateral SVT, probably no need to look any further. But anytime you have a SVT or a DVT in contralateral legs, that almost invariably is a hypercoagulable state, right? So typically, for me, if I see a patient that has SVT or DVT in one leg, that may not warrant for the workup, but I usually try to be as nice as possible to them, so they come back and see me with the next episode a month later, 2 months later, and it's in the opposite leg. Those patients I'm very aggressive about. Remember a case that I had seen a few years back with a guy that perfectly healthy, was a alpine skier, active, very, very healthy, wound up getting an SVT in one leg. We wound up treating it just as chest guidelines were, and he did fine. Wound up coming back 3 months later with an opposite leg SVT and a contralateral leg SVT, and had completely normal reflux studies, no other signs. I wound up working him up to a tilt. He wound up being negative. He actually had hematology workup. I sent him for a chest CT, had abdominal CT, went for a colonoscopy, all completely negative. 2 years later, his mom calls me up and says, "You were right. You know, he had lymphoma, and because you were so aggressive, we kept following up, and eventually he had a bone marrow biopsy and wound up having a low level lymphoma that was discovered." So, you know, you get one of those cases, then you always will remember unilateral versus contralateral, bilateral DVTs, then just be very aggressive, be very suspicious for a hypercoagulable state. And obviously that hypercoagulable state will always be most likely cancer, and occult cancer.
Yeah, thank you for sharing that, Ken. But again, it goes back to Luis, the point you're making, that if you have recurrent SVT, we do need to send the patient to an oncologist just so that we're not missing anything. And it all boils back down to what Dr. Morrison said, that SVT is not as benign a disease process as we used to think it is. So Dr. Morrison, I request you to take this question. This is from Dr. Green. Regarding inflammation, swelling, erythema, and pain associated with SVT, do you ever use a systemic steroid, for example, prednisone instead of NSAIDs?
I've never had the occasion to do that. NSAIDs settle things down pretty readily, and that and drainage of the blood will help. I don't remember ever doing that.
How about you, Luis? Have you ever used steroids?
No, not for SVT. I still think there is a place for low molecular weight heparin. I found that it just seems to do a better job than NSAIDs with regard to anti-inflammatory. I don't use it as much, and most of the time I get away with NSAIDs. But in some patients, I had one patient, I remember, he presented with a phlebitis of the forearm after being admitted to the hospital, and he had clotted all the way up to his axillary vein, and he was on Xarelto, and he came to see me. He was just in a lot of pain. And so I said, okay, we're going to switch you from Xarelto to intermediate dose Lovenox. And after 2 weeks, it just all flared down. So I still think there is a place for enoxaparin if patients are having a lot of tenderness, but I've not used steroids in managing this disease.
Yeah, Luis, I think you're absolutely right. Lovenox has really some significant anti-inflammatory properties, and it'll settle people's symptoms down very nicely.
And sometimes what I do is, if patients are motivated, if they have a lot of pain, I'll put them on Lovenox for 2 weeks and then switch them out to a factor 10A inhibitor, and that seems to work well.
Sanjeev, let me throw something out for more ideas.
Sure.
What would be the, I have my own biases, but what would be the panel's opinion of timing for intervention following an SVT? So if somebody comes in with varicosities that are thrombosed and inflamed, the scan shows that they do have great saphenous incompetence, when would you go, when would you feel, when would you intervene, Luis?
Well,
Great question. We actually have that question from Dr. Hollenbach too.
Oh, okay.
so, if there's no saphenous vein involvement, the minimum for me is 6 weeks before I touch it. And then when they do get treated, they're on some kind of anticoagulation throughout treatment.
And why? Why do you wait 6 weeks?
Just because, they're at risk of a VT event over that time frame, really over the first 3 months.
Yeah.
I don't want to induce a DVT from treatment. I want it to flare down. Overall, 6 weeks is when an SVT will typically flare down. But
I
yes.
completely agree. The longer I can wait, within reason, the better. Up to 3 months, you of course risk having them do it again, but that's pretty darn uncommon.
So Nick, in a situation like that, would you cover your ablation with some kind of an anticoagulation?
No question.
Ken, would you do the same?
Yeah, prophylactic dose, low level, Xarelto or Eliquis, 5 milligrams twice a day, or Xarelto 10 milligrams, typical for me.
And we have another question that has just come in, that how would provoked SVT be treated any differently than unprovoked? Luis?
No, not really. They're both treated the same as far as assessing the patient and determining whether or not they need to have treatment or not. I usually don't do any major workups for first episode SVTs. And I think
so just for everybody's understanding, what would you call a provoked SVT? When is an SVT provoked?
Usually, probably with trauma of some sort. That's kind of the clinical scenario that I would see is someone has trauma to varicosity. Now they got thrombosis of that vessel. I think most patients that I see are unprovoked. They just have varicosities that became phlebitic.
Nick and Ken, would you guys agree that for a first episode of a provoked SVT, you would do the same as Luis?
The only exception that I would make is that, same thing. The only exception is that if it was provoked due to a procedure, then I usually do not. The length of time that I anticoagulate with is probably a little bit shorter because we know what the cause is. And then just to answer, I think it was Dr. Green that had asked about steroids instead of NSAIDs. So yes, I have used NSAIDs. I have used prednisone instead of NSAIDs. Mainly for hypersensitive reactions with the venous seal is typically where I'll use that at. And then also for patients that really can't tolerate NSAIDs, so we see a lot of patients that wind up saying they have a lot of gastritis, they've had bleeding ulcers in the past, and obviously with steroids, you do have a little bit of a risk, but it's a little bit less than with NSAIDs. So in those situations, I have used prednisone, and it does work very well in conjunction with obviously the warm compresses and IND.
That's Ken. So there's a little sensitive question here, which is very relevant and appropriate. Is there data to support anticoagulation post or peri-ablation?
Anticoagulation post or peri ablation?
Yeah, so we all agreed that for somebody who has SVT, when we would go treat them, when we would do an ablation, we would cover that with some degree of anticoagulation. Is there any data to support that?
So what happens when you have when we close some of these veins? Invariably, there's going to be a varicosity that might be connected to it, and then what will happen is the original question was whether or not you treat it any differently than with a induced thrombophlebitis. So in this case, I didn't suggest that we would anticoagulate them. I would suggested that we would treat them the same way, except for with shortened periods. So if there's like a thrombophlebitis that's closer to the junction, then we would treat that, but we treat it closer, or we treat it for a shorter period of time. So if there's an E hit, there's an extension of our clot from the GSV into the junction. Those patients I anticoagulate, but if it's a thrombophlebitis that is an extension from a varicosity, then treatment would still be the same, which is warm moist compresses, NSAIDs. But I was talking more about E hits than anything else.
Okay.
And for those patients, I just treat them until the thrombophlebitis or the E hit retracts back down into the vein that was treated.
That's great. Thank you. And Nick, compression and SVT. How do you use compression during SVT or post SVT?
At the first appointment, they should be placed in compression hose if it's possible, even before they leave the office. So it'll absolutely make those patients more comfortable. In the vast majority of patients, some people will not tolerate it as well, but most of them will tolerate it fine. And if they have trouble getting the compression hose on, then put them in a adjustable compression device.
Luis, you do the same?
Yeah, I get them started with compression hose from the beginning.
And so, Nick, when you do an ablation in these patients, and you said you'd wait 6 weeks, 3 months, is there anything different in your approach there, or it's still done exactly the same way? Would you choose a specific modality, or it's now fair game to do it any way that you would do any other ablation?
Yeah, now that you bring that up, I probably would avoid Venous in that case. Because of the occasional inflammation that you'll see. There's no point in testing your luck as to whether you'll get another SVT. So I probably would. I would also, I think we talked about this a little bit earlier, that patient who had a SVT, I think I'd probably prophylax them during the perioperative course.
Prophylax them with
Anticoagulant.
Anticoagulation. And I think that's what that question was, that is there any data to support that prophylaxis?
Yeah, the answer is probably not, but at least I haven't seen it. But I just think from a medical legal standpoint, if nothing else, if you did not prophylax and the patient got a DVT afterward with a even worse outcome, I think you're in trouble.
Yeah, no, I would agree with you. I have not seen any data either, but I just feel it makes sense. So the honest answer to Dr. Ahmad, who asked that question, is that we are not aware of any such data, but we do it anyway.
I'll you know what, Sanjeev, I personally, for these patients, I personally do not anticoagulate them if there's a clear-cut reason for the SVT. So if they have rip-roaring reflux, that's probably the cause of the SVT in the first place. And usually the thought process behind this is that if you've waited 6 weeks, I don't think you can go wrong. I mean, obviously you're going to be protected, right? But there is a risk to anticoagulation, right? There is a risk to being on Xarelto or Eliquis or enoxaparin. So again, it's just one of those situations where you kind of have to weigh the risk and the benefits for these patients, and it probably should not be an automatic decision. It just depends on what their risk factors are.
Well, that's great. Nick, any other pearls you want to share with everybody on SVT?
I'm all out. I'm all out of pearls.
Okay. Then another question that they've asked is, will there be a chance to listen and watch your presentation again? Absolutely. We'd love for you to watch it as many times as possible. It's going to be on our website. And every one of our presentations is recorded. And guys, again, this is coming to the end of the hour, and just want to really, really thank everybody for joining. Please do not miss our next talk, which is going to be on post-thrombotic leg syndrome. And as you all know, that's a very, very common issue. It's underdiagnosed, but Dr. G. Lachenpaul is going to talk about how should we manage it so that we can prevent it, first of all, and then how do we take care of this disease entity to the best of our ability with all the various modalities that we have available to us now. So,
Sanjeev, before we leave, let me just, I would like to propose a virtual round of applause to a very nice presentation by Luis.
Thank you very much.
How do we do a virtual round? We don't clap?
No, I appreciate it. Thank you, guys.
Good job, Luis.
It was fun.
Luis, that was absolutely an amazing talk. And of course, the panelists made it so much more fun. Thank you, Nick. Thank you, Ken. And look forward to seeing all of you for our next talk. Thank you, guys.
Thank you.
Thanks a lot.